Let's welcome our next speaker, Dr. Otto Metzger, Associate Medical Director of International Strategic Initiatives at Dana-Farber Cancer Institute and Assistant Professor of Medicine at Harvard Medical School. Dr. Metzger will be presenting on integrative therapies, obesity, and breast cancer.
Good morning, everyone. It's a pleasure to participate in this conference. It's my first time in the Cayman Islands, and it's been fascinating to get to know people from here. So I want to thank, again, the organizing committee for the opportunity to present. I want to thank you, the Ministry of Health. And so far, this has been a very well-attended conference. It's impressive to see this room full on a beautiful day in the morning. So the topic of this presentation, it's very well aligned with the previous talk that we just heard from Dr. Bloomberg, which is about integrative therapies and the importance of treating patients as not just with regular medications, but with sort of like a more general and holistic way. And I also want to talk a little bit about links that exist between obesity and breast cancer. And it's, again, aligned with lifestyle interventions that could have very good impact on health. So when we think about complementary and supportive therapies, the goal for this presentation is for us really to reveal what is the evidence that we have, what is the data that has been generated from clinical trials about how can we use integrative therapies. And what are integrative therapies? And basically the definition is very broad. We're talking about treatments that are focused on the whole person, that are informed by evidence. We want to know how these things, different supplements and vitamins and so on, they work. And we want to make use of our appropriate therapeutic and lifestyle approaches, healthcare disciplines, really to achieve this goal of optimal health and healing. And there are very important and some key concepts when we think about integrative therapy. So these are treatments that involve integration of various forms of treatment for an individual patient. In oncology, my area, we have these traditional medical treatments that include surgery, chemotherapy, radiation therapy. And the goal is really to treat the whole patient by adding these complementary therapies, taking into consideration all the classic treatments that we offer to patients. And there is no standard list of integrative therapy, and I would say that any kind of treatment that's not a drug, surgery, radiation could be considered an integrative therapy. Here I have some examples of integrative therapies that have been studied and commonly used in our practice in Boston, such as acupuncture, we have yoga, musical therapy, meditation, special diets. So there are many examples of potential integrative therapies. And the reality is that the great majority of patients dealing with a diagnosis of cancer, they get to use some sort of integrative therapy throughout the journey since the diagnosis. The number can be as high as 90%. And we have a small study here with just over 200 patients with advanced breast cancer. And the majority of patients, they do use some form of integrative therapies. About a fourth of these patients, they use many types of integrative therapies. And when we asked in this study, what were the therapies that patients were using, it's a mix. It's a mix of herbs, massage, naturopathic treatments, acupuncture. And in reality, patients, they really don't tell us as clinicians what are they are doing and the details of what they are doing because they feel that this is sort of disconnected from the care. But the goal is different. The goal is for us as clinicians, while using classic medications like chemotherapy and so on, really to consider and to think about the importance of the integrative therapies. So why there is so much interest in integrative therapies if cancer care is advancing so quickly and we're curing more and more patients with more drugs and novel and therapies? And the reality is that we do have a very large number of patients who were cured from cancer. Here, the number goes up to 20 million data from the United States, and this is growing exponentially. And those are patients who were diagnosed with cancer in the past, and they are cured, and they are back to their lives. And it's very important for us to study what is happening to these patients in what we call a survivorship phase, where when they are off the active treatments. And as I said, as the treatments get better, this is going to grow exponentially. We have 20 million people in the US living with a prior cancer diagnosis. This is going to grow and grow and grow. And many of these patients, they do suffer from adverse effects from prior therapies, sometimes even psychosocial problems for having dealt with a cancer diagnosis in the past, and many toxicities that may continue over time. And this is an area that's really understudied, and we have very little data really to understand what is the impact of therapies on long-term outcomes in terms of quality of life and so on. So here, it's a good example of the prevalence of severe fatigue after completion of breast cancer treatment. So those are patients that have completed the whole active treatment for breast cancer. They are potentially cured from breast cancer, and we can see here that the overall incidence of severe fatigue to be as high as 27%. So we really need to understand what's causing this and how can we address a side effect or a symptom that could have really very bad and long-term impact in terms of quality of life, in terms of having a patient readapted into their life after cancer diagnosis. And in this study, there were risk factors that were identified that were related to the disease, related to the treatments, but also psychosocial aspects, like not having a partner was one of the risk factors related to this incidence of fatigue. So we need to see this long-term effects, not just as a cancer treatment related, but they're like multifactorial. And this has links with our previous presentation from this morning, where it's very important to address a patient as a whole and considering all the psychosocial aspects, spiritual care, and so on. So the integrative therapies, they're really appealing treatments for cancer-related side effects. They usually don't require a prescription. They are generally less likely to have side effects. I would say here that supplements could be an exception. In the US, patients, they do have access to a large number of supplements. They go by themselves defining what they should take. And sometimes those are things that are not so regulated, and there could be side effects that we don't know. But the integrative therapies in general, they are viewed as more natural, and they're widely adopted by patients thinking that this could be like good supplements as an example, and give patients a sense of control over their own health. So they're really dealing with symptoms after a diagnosis, and they go by themselves trying to find alternatives and supplements that can make them feel better. But the real question for us in medicine is, what is the real evidence that this type of approach to the integrative therapies could reduce side effects of cancer treatment? And in reality, there has been very limited research evaluating the impact of integrative therapies, despite the fact that those are interventions that have been used for centuries. And most of the research showing the value of integrative therapies have been on small clinical trials and not necessarily with a comparison group. And as a clinician trialist, I would say, if we really want to see what's the impact of an intervention, we really need to have a randomized clinical trial. We need to have a control arm. We need to have a comparator. Otherwise, the information can be misleading, and we're not able to really to dissect what's the benefit of what's being offered. And there are a few more recent trials that have shown benefit of integrative therapies in cancer patients, and I'm going to review those studies with you quickly. Just to give an example of the importance of running these clinical trials, which are not necessarily easy to run because we're not testing a blockbuster drug that's bringing a lot of revenue for being an expensive and new medication. We're testing things that not necessarily have a financial supporter. So those are not easy studies to run, but there are mechanisms to have them conducted. And as we evolve and as with technology, we should be able to run clinical trials in a more pragmatic manner and hopefully in the near future use data from our own clinical practices to understand the impact of these interventions. Oops, sorry. So I'm just trying to get back to the slides here. It's a bit slow. Do you know how I can advance these slides? No, I'm trying to go forward. That's a good, just one back. Perfect. So one of the side effects that we have in breast oncology that's very common, it's the arthralgia and side effects associated with the use of aromatase inhibitors, which are basically pills that the patient takes if they had estrogen receptor positive breast cancer. Those are medications that patients take daily for usually 5 years at the minimum. And the reality is that those medications, they are not well tolerated. The discontinuation rates can be as high as 20%. Up to 40% of patients, they stop taking these medications. And the early discontinuation and non-adherence to these medications, they are associated with worse survival outcomes. So patients have more relapse, the survival rates can decrease. So those are important medications, but they are not well tolerated, and patients are taking them for years. Arthralgia is the most common side effect with this medication, and it's reported in up to 50% of patients. So our colleagues in the US, they did a study through the SWOG, which is a clinical trials group, one of the clinical trials groups supported by the National Cancer Institute. And basically, they did a study with 200 patients to evaluate whether acupuncture could be of benefit in treating patients who were having arthralgia with aromatase inhibitor. And patients were randomized here to a true acupuncture, a sham acupuncture, and a wait list control. And here, after 6 weeks, you had the primary endpoint of the study to be ready to see what's the impact of this intervention. I'm still having some problems to advance these slides. So the true acupuncture here, it's basically could be given in 2 forms. The standard traditional Chinese acupuncture, that's basically a 30 to 45 minutes per section, or a full body joint-specific acupuncture tailored to the most painful joints. The sham acupuncture here was probably very difficult to implement in terms of how you do a clinical trial, but it's important to increase the accuracy and the interpretation of these results, which is basically a shallow needle that was inserted, but not necessarily to work as a real acupuncture, really to give a perfect comparison here to demonstrate what could be the impact of the true acupuncture for these patients. So here in summary, I have the patient characteristics, and we can see that across the study arms, patients were taking aromatase inhibitor for about 1 year on treatment when they entered into this clinical trial. And we can see here, we have scales to measure how much pain patients were experiencing at the baseline with this baseline score. And we can see that this was also well balanced across the study arms. And when we see here the results, here the true acupuncture on the left, the higher the bar, more effective it is in reducing the arthralgia. So in comparison here of the sham acupuncture and the wait list, we can see that this was an intervention that was really able to help patients with these side effects. It's obviously a treatment that's not easy and maybe widely accessible to everyone, but it's very interesting to see an integrative therapy being studied on a well-conducted randomized clinical trial and really demonstrating the benefit here in mitigating a side effect that's really bothersome. There was another study that we were involved, which was also evaluating acupuncture for patients with hot flashes for patients with breast cancer. And here the hot flashes is another side effect that we have with the classic hormonal therapies and tend to be really prevalent for patients who have estrogen receptor positive breast cancer and taking these medications. Again, when we think about endocrine therapy and patients taking this pill for 5 years, those are interventions that are very important for us as oncologists because they really reduce recurrence and death by 30 and 50%. But it's also equally important that patients tolerate this because they're taking this for many years. And endocrine therapy is associated with hot flashes. This has an impact on quality of life. That has an impact on sleep. Patients wake at night with hot flashes. And basically, it, again, very prevalent. And the medications that we have in the clinical practice to mitigate side effects like hot flashes, like venlafaxine and gabapentin, they have some efficacy, but they're not great medications. So here, we got involved in a clinical trial that had a very interesting design because it involved 3 different countries. And basically, instead of having a single study conducted internationally, what we did was to have 3 different independent clinical trials that were exactly the same. And this has links to how we do clinical trials and how can we optimize data gathering and information as to facilitate knowledge and improve patients' treatment. So basically, we have these studies that were basically the same clinical trial, but conducted as independent studies. So basically, we wouldn't need to have a global study with all the liabilities of running a global international trial, but like individual studies that were pre-planned to be conducted the same way and to be analyzed together. So the patient population included patients with estrogen receptor positive breast cancer, pre or postmenopausal, and patients who were taking hormonal therapy and who had persistent hot flashes. And here, when it's persistent, it's occurring for at least a month and with more than 14 episodes of hot flashes per week. So at least 2 hot flashes per day. So those are side effects that are really interfering with patients' quality of life because they're having hot flashes on a daily basis. So here's just a schematic design of the clinical trial. Patients were basically randomized to this 10-week session of acupuncture versus usual care, and they were followed with scales to measure hot flashes. Here it's the demographic and clinical characteristics of the population. Here we have, as I said, the 3 individual clinical trials analyzed together. And we can see, sorry, I'm still having trouble advancing this. We can see here a well-balanced distribution of race. When we think about clinical trials and interventions, we don't want to have this being done just in Caucasians. We want to have a widespread distribution of race so we can see what is the impact in different patient populations. Here, it's the baseline number of hot flashes per day. So patients on this clinical trial were having 6 hot flashes per day. It's really a high number of hot flashes. They're really very symptomatic. And the time between cancer diagnosis and study enrollment here was greater than 2 years for these patients. But the goal, again, was really to evaluate the impact on hot flashes. And here we have the results showing acupuncture in blue and the usual care in orange. And we can see this difference, this big decrease in hot flashes with acupuncture as an intervention for hot flashes. And when we look here into a more like numerical way, we can see that the number of hot flashes in a given day was reduced. And once we use standardized scores like the hot flashes score, we can see this very significant benefit with acupuncture reducing hot flashes. So again, Another example of an integrative therapy that has an impact in reducing adverse events and potentially with huge gains in terms of quality of life. The challenge that we have with acupuncture in general is that those are studies that were conducted and patients were exposed to this for a relatively short period of time, and we don't know how feasible it is to have it done continuously in terms of access, costs, and so on. And we also, in reality, we don't know if this could have a potential benefit in improving hot flashes at a long term, maybe with a reduced schedule of acupuncture. But again, those are studies that are very difficult to conduct, and the data that we have, it's just with this short intervention showing a benefit. And when we look at the percentage of patients in this study that had a reduction of hot flashes by at least 50%, we can see that this was like 64% in the acupuncture arm and 18% here in the usual care. So again, we need to have this comparison. Otherwise, we don't know what's the real difference of your impact if you don't have a control arm on clinical trials, because some patients here in the usual care, sometimes hot flashes they can reduce by itself just because patients get adjusted to the medication. So the comparison is very important for us to understand what's the magnitude of benefit that we're getting with the intervention. So now I want to switch gears and talk a little bit about this link that exists between obesity and breast cancer, and also between obesity and cancer in general terms. So I want to review some of the observational data that we have linking obesity and related factors to breast cancer, and talk a little bit in more details about some of the ongoing studies that we have to define the role of lifestyle and obesity management in terms of cancer prevention. And there are some like emerging data about the weight loss medications and cancer that we're going to talk as well. So here in 2016, we had this important publication from IARC, a working group, really evaluating what's the relationship between obesity and cancer. And there were 13 malignancies that were associated with an increased incidence of cancer. We have here this list of all cancers that increase in incidence if you have an obesity in the population. And here we have like pancreas, liver, gastric, thyroid, multiple myeloma. And here, our focus given at Boston College, this very high increase in risk in breast cancer with every 5 kilograms per meter square increase in BMI. So basically we have this 10% increase. So it's really, it's not trivial. We think about breast cancer being as a very prevalent disease. So the impact of obesity here, it's real and touches a large number of patients. I'm sorry, I continue to struggle here. And what is the data that we have about interventions that could fix obesity in some way and the link with breast cancer? So here we have this publication from a few years ago trying to understand what's the impact of bariatric surgery and breast cancer risk in a very large population. So here we have 18,000 patients who underwent surgery versus matched controls. The patient age and BMI, here the BMI was very high at 44. The median follow-up for surgery and control was in the range of 40 months. And what did we see from this? The bariatric surgery as an intervention reduced, in relative terms, the chances of patients who were in the postmenopausal setting to develop a breast cancer in 46%. And here, the effect was also important for premenopausal women with a 38% reduction in relative risk. So in reality, if this were a medication in oncology showing this level of magnitude, this would be a new blockbuster drug that would have a huge impact and be widely adopted. But here, I'm not saying that we should indicate bariatric surgery to everyone, and they're like the classic indications, but this is just a nice demonstration of what can be achieved by lifestyle interventions and weight management in relation to the incidence of breast cancer, which again, it's a prevalent disease. And here we also have data showing what are the relationships between obesity after breast cancer diagnosis. And we can see here that the BMI and all-cause mortality, there is an association with increased BMI, there is increased chances of mortality. And there is also an increased risk and incidence of second cancers. So here, it's another example of a potential area for impact, which is lifestyle interventions and weight management for patients who had a diagnosis of breast cancer, with information showing that there could be advantages in terms of survival outcomes and in terms of prevention of secondary cancers. And what are the clinical trials and large randomized clinical trials that are being conducted to evaluate the impact of weight loss on breast cancer recurrence? Here we have these 4 clinical trials, Be Well, Diana, Success, and the LISA trial. We can see here that eligibility of these clinical trials, they were relatively similar, with some variations in terms of the thresholds for BMI. And the intervention here was at the minimum with a 2-year weight loss management intervention. And the outcomes that we're trying to achieve with this study, it's really prevention of recurrences. Here we have the first study, the LISA trial. We can see here the numbers. This is a study that was unfortunately stopped earlier, so the sample size here is not reflecting what had been planned before, so we need to interpret this with caution. And we can see here that despite relatively small numbers, what is important here is what they achieved in terms of the weight loss intervention that was 5% at 1 year and 3% at year 2. And we see a separation of the curves in favor of the lifestyle intervention. But of course, here numbers are small, and this is not a definitive study. A larger study, the Success SEAT clinical trial, basically didn't show a benefit. We can see here that the 2 curves, the blue and the red curves, they are overlapping. But what is important here is that what they were able to achieve in terms of weight loss at year 2, and I would say that maybe a 2% reduction in weight at year 2 may not be what is needed to have an impact in terms of breast cancer prevention. The second aspect is what is your population being studied? What is the maturity of the data? How many patients really were contributing here with events to allow us to have a real power, statistical power to see differences here. And we can see that the curves in the initial years, they're really demonstrating good outcomes for these patients. So maybe you might need to, you would have expected to see a larger gain in weight loss reduction, maybe to see a real difference here. And we have the Be Well trial that's being conducted by a colleague of mine, Jennifer Ligbell at Dana-Farber in Boston. This is a national clinical trial with support from the government that took her about 10 years to get it funded and out of the ground. And it's very nice that this is a study that's ongoing and achieving maturity. And she presented some data, some of the initial results at the ASCO annual meeting recently. And basically, this is a very large clinical trial. Jennifer is an expert in this area, so she put so much effort into the educational material and the intervention from this clinical trial. It's really a beautiful project that has enrolled over 3,000 patients with stage 2 and 3 breast cancer. So a population with a slightly higher risk. Patients could have either estrogen receptor positive or triple negative or HER2 positive breast cancer. They had to have a diagnosis within 14 months prior to study enrollment and a BMI greater than 27. So patients were basically randomized to get this health education through a telephone-based weight loss intervention or a health education alone. So basically she has a research staff in our hospital that basically follows all these thousands of patients and contact these patients on a regular basis, provide them with a lot of information. There is a lot of coaching and information to patients to help them achieve a change in weight and be healthier. And the primary objective of this study, it's basically invasive disease-free survival. So it's a bold endpoint, She's doing this to demonstrate that the weight loss can work as a medication in preventing recurrences. And the secondary objective here, which she presented at ASCO, is the weight change. Let's see if I can show the patient characteristics here. So basically, we have a very large clinical trial that's now enrolled in follow-up. The median age of these patients is 53. The BMI of the population enrolled in this clinical trial was high. So basically, patients had a BMI of 34 in both the intervention and the control arm. We can see here the distribution of race, and as expected in Boston, the majority of patients were Caucasian and white. And here the breakdown by ER status. As expected for breast cancer, the majority of patients had estrogen receptor positive. I would say that's going to be very interesting to see, because here we have 20% of patients who had triple negative disease. And from a scientific standpoint, there's a lot of interest for us to understand if this effect of weight loss intervention has links with estrogen, given that obesity can be associated with higher estrogen levels. So it's going to be very interesting once this reaches maturity to see whether the intervention is efficacious in preventing recurrences by the type of breast cancer, if this is going to be more pronounced in estrogen receptor positive, or maybe also effective for patients with triple negative disease. So the majority of patients enrolled in this clinical trial, by having stage 2 or 3 breast cancer at the diagnosis, they were treated with chemotherapy, 80% in both arms. A fair amount of patients received radiation. And here we have the results that were presented recently, showing the benefits at 6 months in terms of weight loss change. And we can see that the intervention is effective. We can see that in absolute terms, patients were losing on average 4.4 kilos. So it's really a real change. When we see from a percentage standpoint, it has like close to 5% change in weight loss at 6 months. So when we go back to what I just showed from the previous clinical trial, where the intervention led to a 2% reduction, it's going to be very important for us to follow these numbers carefully to see. We're just going to get a definitive answer to the effect of the weight loss on prevention of recurrences if the weight loss is achieved and if it's maintained over time, which can be difficult. That's the challenge of doing clinical trials like that. And we can see here that the control arm of the study, patients basically they maintained their weight at baseline, which was in the obesity or overweight category. And here, interesting, when we follow patients who have been on treatment on this clinical trial for a year, it's nice to see that this is sustained. We're still seeing the same amount of weight loss and a 5% reduction that seems to be stable over time. This is, again, very important as we're trying to see the effect of weight loss on a risk that's spread over many, many years after the diagnosis. And here we have this a breakdown of pre versus postmenopausal patients, which is also interesting. And we can see that the postmenopausal patients, which is the majority of patients enrolled here, the percentage of weight change with the intervention was over 6%. So it's really, we can see that this intervention that Jennifer planned so well seems to be working, and patients are maintaining a weight loss over time. So one area that's going to become more and more critical for us to understand is what is the impact of these new medications that we're all hearing about, that they're getting a lot of press, and they're effective as medications for weight loss. Just briefly, one of these studies with semaglutides for patients with overweight or obesity. Here we're not talking about cancer, just the medication for a population of close to 2,000 patients who had a BMI over 30, where patients were randomized in a 2-to-1 fashion to get the weight loss medication versus placebo. And we can see here the mean change in body weight at 68 weeks of follow-up with these medications being 15%. So it's really, as we can see here in these curves and the graphics, it's really, those are medications that have a real impact in weight loss for obesity in general, but we don't have as much data to understand what could be the impact from a prevention standpoint, what percentage of patients on these medications that may have a reduced chances of having multiple types of cancer for having lost weight on a medication. Basically, the data doesn't exist yet. There are like a mix of smaller studies evaluating the impact of these medications on cancer, which is shown here on this meta-analysis that's basically trying to compile data from multiple clinical trials with a large number of patients that were treated with the GLP-1 receptor agonists and the breast cancer risk. And we can see here that in absolute terms, there was no big difference. If anything, we saw a numeric increase in breast cancer risk with these medications. And when we interpret the data from the meta-analysis in general, I would say that the jury here, it's still out, and we don't have like a clear evidence about the potential impact of these medications in prevention of recurrence. I would say that there is a need here for us to do more clinical trials and really to have a very large trial to try to understand what's going to be the potential impact of these medications in prevention of recurrence. So basically, we cannot rely on this meta-analysis and small studies to draw any real conclusion here. So the jury is still out. So in the next few minutes of this presentation, I want to try to take all that we discussed here in these initial parts of the presentation and tell you about how we go by and how we deal with integrative therapies at the Dana-Farber Cancer Institute in Boston. And basically what we did, and in 2000 we created what's called the Cayman Center for Integrative Healthcare Therapies. And basically the idea behind the Cayman Center was really to have a core of people that would be responsible for the integrative therapies and really to put the evidence into clinical practice. Really to provide patients with some guidance, because patients, they have access to so many different interventions, and we felt that we needed to have a center to provide them with real guidance about how to go and deal with the integrative therapies. So this was created in 2000, and really to create this bridge between the traditional and integrative medicine. Basically, this is within our main hospital, where patients can have appointments at the Cayman Center. And here's just a picture of the Cayman Center in itself. The clinical services include the appointments. We are really growing a lot since the pandemic with what we do in terms of virtual medicine, and also these group programs through telemedicine and outreach programs. And this is really very, very interesting, because with digital medicine, we should be able to have a much broader reach than what we do with the just inpatient in-person consultations. But we also have this integrative medicine consultations for cases that are more complex, and we really have an expert that's going to be able to review a patient history, the medications in detail, and really try to come up with a plan that's focused for an individual patient. As I said, we're fascinated with this virtual appointments. We have virtual appointments for exercise consults. So I have patients who live in different states, and they do follow up with the Cayman Center through the internet. And they really like it, and they are committed to it, and they see value in terms of quality of life. This stool here, it's sort of annoying. And as I said, we have the virtual and in-person programs, and this keeps growing exponentially. We're offering like exercise, yoga, dance, Tai Chi, and a lot of different things that are really patients really feel that's very helpful for them. And we as a cancer center, that we're very academic, we feel that it's very important for us as a mission to be on top of the integrative care therapies and provide patients with access to things that we know that there is a benefit and no harm to patients. So it's really critical for us. The virtual program is growing exponentially. There is this focus on nutrition, exercise, meditation, and expressive arts. Here we have numbers of patients who have been registered through this virtual programs, and those are things that grow exponentially because all patients have access from their own home and from their cell phones, and they really get the information that they want to understand about integrative therapies. Sometimes we don't have much time or even knowledge to talk to all patients about the integrative therapies, and as a clinician, it's very nice to have the ability to refer them to the Cayman Center for the virtual interactive courses where they can do mind-body medicine programs over time. And really, it's very important. And again, the goal is to offer patients access to integrative therapy within certain boundaries because we don't want patients to be taking supplements that we don't know much about, things that could have adverse events or interaction with medications that they are taking. And we also have specific programs that are being created and tailored for specific patient populations, such as Living Well with Breast Cancer. It's basically a program for patients who have metastatic breast cancer. Thankfully, we're seeing many patients living many years and dealing with difficult treatments for many years with this disease. And it's very nice to have specific programs to help patients go through this cancer journey with better quality of life. Here, numbers again of patients attending these virtual programs. We can see here on the right that numbers are reaching like 400,000 visits. So it's really very popular. And since the pandemic, we're learning that, again, these virtual platforms, they can be very, very important for cancer population. And we also have, and this is sort of like an evolving area, where we have symptom management toolkits. Those are basically interventions that are addressing specific problems that could be important for different types of cancer. So the sleep medicine is one, neuropathy, it's a complication that we have, a side effect from many cancer treatments from many types of cancer. Fatigue, it's really important, as we showed before. The prevalence of fatigue after cancer treatment, it's real. And we have anxiety, which is in development, and so on. So it's really a booming area, and we're hoping that those are things that are not just going to be available to patients, but help us generate data demonstrating the impact of each of these interventions. So to conclude, I just want to acknowledge Jennifer Ligebel, who is the principal investigator of the Be Well clinical trial. She's the coordinator and the head of the Cayman Center in Boston. She's a fabulous clinician, a friend, and it's really remarkable to see someone like Jennifer moving on with very important research in an area that's very difficult to do research because, as I said, it's difficult to get funding, it's difficult to execute, and she's really a force behind all that I was trying to explain during this presentation. So I want to thank you everyone for your attention.